Hello, and thank you for joining our live webinar, Experience with iOCT, Achieving Better Patient Outcomes. On behalf of our panelists and everyone at Haag-Streit Surgical, we would like to extend a very warm welcome and hope that you find the webinar both informative and inspirational to see how interoperative OCT can benefit you and your patients. My name is Mike Luley, and I'm the Director of Sales and Marketing for Haag-Streit Surgical in the United States. Joining me is Florian Kaiser. Florian is the IOC Product Manager for Haag-Streit Surgical based in Hamburg, Germany. We have a distinguished panel of experts that will be sharing their experience with the Haag-Streit iOCT and how it has helped them to achieve better patient outcomes. Dr. Francis Price and Dr. Matthew Fang are both cornea refractive specialists with the Price Vision Group in Indianapolis, Indiana. Dr. Christopher Riemann is a retina specialist at the Cincinnati Eye Institute in Cincinnati, Ohio. Dr. Robert Zaldivar is a refractive specialist at the Instituto Zaldivar in Mendoza, Argentina. And Dr. Sebastian Siebelman is a cornea specialist at the University Clinic of Cologne in Germany. We invite you to contact us for more information, either by email at sales-surgical@haagstreit.com or through our website at hsmicroscopes.com. You can also contact your local representative. The iOCT is available globally. However, there is a 510(k) pending in the USA. We'll begin with Dr. Siebelman discussing pediatric OCT, followed by Dr. Price discussing DALC, Dr. Fang discussing DMEC, Dr. Zaldivar discussing ICL lens placement, and finally Dr. Riemann discussing posterior segment OCT. Dr. Siebelman, we'll begin with you.
So, dear Mike, dear ladies and gentlemen, thank you very much for the kind introduction and welcome from Germany. Today I would like to give you an introduction into the topic intraoperative OCT in children with anterior segment anomalies. And one second. And as you can see, this topic was in the beginning of the development of intraoperative OCT, not only a challenge for ophthalmologists, but especially for anesthesiologists, as children had to be placed in front of such office-based OCT devices for sufficient OCT imaging. So this was pretty hard. And later, handheld devices have been developed, but the main problem with these handheld devices was, on the one hand, that the reproducibility was not very good, and on the other hand, there were a lot of pronounced artifacts present. Some years later, so-called microscope-integrated OCT devices were developed, and this photo shows the first worldwide developed microscope-integrated OCT from the year 2010, where the OCT scanner was already integrated into the microscope head and the OCT imaging was shown on external displays as seen here. And today these devices are commercially available as shown here, the iOCT of the company Haag-Streit Surgical. And this device allows OCT imaging to be displayed not only on an external display, as you see here, but also on a heads-up display, as you can see here, and by means of a direct projection into the eyepieces of the ocular. So these microscope-integrated devices have a number of advantages over previous devices, such as a very good correlation between the cross-sectional OCT image and the microscope image. You can image during your surgical procedures without any interruption. The artifacts are absolutely reduced compared to the handheld devices, and they allow a precise positioning of the OCT beam by the foot pedal control. And compared to the fewer gold standard, to the ultrasound biomicroscopy or the UBM, they have a much higher resolution and are absolutely contactless. So with regard to my topic today, I would like to show you on the basis of some selected patients how intraoperative OCT can improve the diagnostics as well as the operative therapy of children with anomalies of the anterior eye segment of the eye. And in Cologne, we already investigated more than 45 newborns and children with this device, as you see here on the right image. This is a typical intraoperative setup. And these children were aged between 12 days and 14 years, and indications for the examination were congenital corneal opacifications mainly, but also sclerocornea, Peters anomaly, limbal dermoids, glaucoma, cataract, uveitis, GVHD, ROP, and so on and so on. We were able to publish these results in various journals, and with the next slides, I would like to show you examples of children where we successfully have used the MI-OCT with great benefit. For example, allows the MI-OCT for the depth estimation in corneal opacifications. As you can see in this little patient, this is the eye of a 1-year-old child, and here on the microscope image before the surgery or at the beginning of the surgery, you see a corneal scar after the injury by a fingernail, and you can't really estimate the depth of the corneal scar, but the anterior segment OCT image exactly shows the depth of the scar, and you can see that it's only a superficial scar in the anterior corneal stroma. And so we decided to perform some anterior lamellar keratoplasty in this child, and you can see here at the end of the surgery the cornea is much clearer, the graft is adapted very good, and the scar is completely removed. Here another case that illustrates in a very good manner the depth estimation of corneal opacifications by MI-OCT. This is an 8-year-old boy, the left eye. It also shows this distributed, we called it hypertrophic corneal scar. And the OCT again shows that the scar is only in the anterior part of the cornea, in the corneal stroma, and we decided for only a lamellar keratectomy and for an excimer PTK. So in combination, both. And at the end of the surgery, you see that the scar is completely removed. Moreover, the MI-OCT also allows a depth estimation during the excision of such corneal or limbal dermoids. In this kind of surgery, you really have a bad view into the anterior chamber. Most parts of the corneal tissues are really clouded, and in this 1-year-old child, we could see that here you cannot really estimate your residual stromal bed, but the OCT nicely shows how much cornea still is left and how much you can go when you decide to excise this dermoid. And this is at the end of the surgery. You can also investigate your amniotic membrane patch. Here you see a nice double layer of the amniotic membrane. You see that the scar tissue is nearly completely removed and the graft is adapted very good. This is a very important case in my eyes. In fact, the MI-OCT allows to differentiate between a Peters anomaly and a simple corneal opacification. So this child, we believe this is absolutely a Peters anomaly. So we decided for examination under general anesthesia. It was a 5-month-old child, but the OCT, so we were really surprised. The OCT only showed the superficial scar, and we also decided for a lamellar keratectomy combined with an excimer laser PTK. And you see a nearly completely clear corneal stroma at the end of the surgery. Here a little bit cloudy with a contact lens and with the reflexes of the operation microscope light. And the OCT shows in a very good manner that the scar is nearly completely removed. The chamber angle is configured in a physiological way. The lens is clear. You can also see a contact lens. So you can really decide if this is a Peters anomaly or if it's only a corneal opacification. So in summary, the MI-OCT is a safe and non-invasive imaging technique which adds important information during the surgery of the anterior eye segment and in our eyes should be in future a gold standard during the examination of newborns and children or the disabled people under general anesthesia. But we also have to say that so far there are no or only very few prospective randomized studies regarding MI-OCT, and especially no studies comparing the surgery with MI-OCT versus without MI-OCT. Thank you very much, and I'm happy to get your questions.
Thank you, Dr. Siebelman. Do we have any questions from the panel?
Yeah, this is Chris Riemann. I'm a retinal surgeon, so pediatric cornea is quite far removed from what I do. But that was a really fascinating talk. And a question I had for you: when I look at the anterior scars that you're removing, how often do you remove those manually, and how often do you remove those with a laser? Both in terms of creating the graft as well as creating the bed for the graft to sit in.
Well, it depends a little bit on the depth of the scars. If they are deeper, we always remove them manually. But what we do is that we, in most cases, perform an first manual keratectomy, and later we do an excimer laser PTK. So we do both. So depends on the depth and on the configuration of the scar. So this is really yeah, these are very individual cases.
Dr. Siebelman, great cases there. Thanks for sharing. Have you encountered yet a corneal opacity that can't be penetrated by an optical system like the intraoperative OCT?
Not really. No, I never had one, and I was really surprised that in very many cases the OCT is really able to get a good image, and not only regarding the cornea, also the retina. We always have also in such patients have a view on the retina. We also look at the optic nerve head, and we, in many cases, we can really get good images of the optic nerve head, even if we cannot see it clearly with a lens.
So one of the reasons for that is that the OCT laser images in the infrared range, which penetrates better. Florian, yes. What is the wavelength of the OCT imaging laser?
Sorry, say it again.
What is the wavelength of the OCT laser?
He has the old OCT, and it's 840 nanometers.
So infrared, near infrared.
Yes, infrared, near infrared. That's right. Okay. If we don't have any questions from the panel, we have 3 more questions from the audience. I will just read the first one. Hopefully, there's so many new words for me. I'm gonna try to read it. In the suspected Peters anomaly, was gonioscopy possible under anesthesia, and what was visible?
Yes, the gonioscopy was possible, and the chamber angle was configured normally. So there were no synechia or something like this. So this was absolutely no Peters anomaly.
Okay. Then the other question is it also possible to examine the optic nerve and the retina of the children with the iOCT?
Yes, absolutely. So it's possible to examine the retina and the optic nerve head. So it's a little bit, so the image quality is very good, but we don't have these office-based tools like these standardized scans for the optic nerve heads. But it's also very good to scan the optic nerve, for example, for a follow-up if you have several examinations under general anesthesia. So I don't know how you handle this in the United States. So we have some children where we really investigate them, for example, every 3 months, every 6 months or so under general anesthesia when they are very young and have some problem with glaucoma or so.
Okay. Another question is, why is MI-OCT better than UBM? What are the advantages on that?
Yes, very good question. So in my opinion, the most significant advantages are that on the one hand, it's really contactless. So you don't have to interrupt your surgical procedure. You can really stay at the microscope and see the images, and the resolution of the images is much better. For example, we also compared it to UBM, and the depth estimation, for example, of structures or corneal scars also is much better when you use intraoperative OCT than when you use UBM.
Okay, great.
So I'll jump in. This is Chris. I'll jump in. I also think I completely agree. The UBM is not coupled to the surgical microscope. It's not coupled to the focus of the microscope. It's not coupled to the zoom of the microscope. And sometimes with the UBM, it's difficult to know exactly where you're scanning. Whereas with the microscope integrated OCT, you know exactly where you're scanning because it's projected for you in the oculars or on your OCT.
Yeah, exactly. The reproducibility is much better in my eyes, and even if you have an open eye, so when you have some paracentesis or so, and you have to you don't want to touch the eye, then the OCT is much better.
Okay, great. Thank you very much. Then I'm gonna switch the presenter to Dr. Price.
I'm gonna build on what Dr. Siebelman told us and do a little bit of an introduction of intraoperative OCT. And I'm also going to talk about DAUC and kind of expand on what we just heard in Dr. Siebelman's talk. And I think one of the key points that he showed was that you can actually use the OCT to do layered dissections in the cornea when you have scars. Now, when you're out looking for a surgical OCT, I think there's different features that are very important. And one of those, and the most important one, is the quality of the image that you see in your ocular, because that's really the determining factor that makes intraoperative OCT a surgical tool as compared to a hobby or a research endeavor where you have to look off at the video screen all the time, because you can't do it real time with a video screen. But the video image is the next important thing for talks and so forth, and for your staff. Ease of use is important, whether it's an integral part of the microscope or something separate. And I wish I could tell you that shopping on cost would be helpful. And until we all start buying more of these, it tends to be expensive. Now, what I've shown here, I think, is really the meat of my talks. And this is an iPhoto that we took with a phone through one of the oculars. And what this shows us is what the injection image looks like. And this is what really differentiates Haag-Streit from the other devices that are out there. So let me walk through what you see here. Here is the view of the cornea, and there's a little bit of reflection from the injection image. This blue line here is where the OCT image is being taken. And that can be rotated with the foot switch 360 degrees. What we have down at the bottom is the injection image, and we can see a very good view of the cornea. It's folded over here because what we're interested in and what we're focused on is this area here. And this is a DMEC graft in a 43-year-old donor that's tightly curled. And you can see the tight curls here. And so as Matt will tell you, we don't use any marks on our donors when we do DMEC. We just use the OCT to tell us if it's oriented appropriately. We do our own donor preps, and so we don't have to put stamps on them or cut out part of the graft. We can tell real time what's going on. And this has made a huge improvement for us in our surgeries. Let me see how I get going here. Now this is what you saw already. This is a Haag-Streit microscope. The OCT is right here. It can be removed. It goes onto the beam splitter. It's injected into both oculars. And this is the monitor that's on the microscope. And you can look there if you want to see that, or your staff can, but that's also where the control panel is. And so this shows you the three ways that you see the OCT image in your operating room. The important one for the surgeon that you use real time is here. This is what the surgeon sees. And this line and this injection image goes on and off with your foot switch whenever you want it. Now, whether your foot switch is on or off, you'll see the OCT image here on the monitor that's on the microscope. And this is a wall monitor that shows the usual video of what's going on in surgery. And the inset here that can be moved around is the OCT image. Now, it's important to understand what we're seeing here, because this is the surgeon's view on the left, and here is the view that you're going to see in all the videos we show. You won't see where the section is being made, and you won't see the injection image. So these are the videos you're going to see, but this is what you see in surgery if you have one of these intraoperative OCTs. Now, I think where it's really going to make a big difference is our ability to do really good deep anterior lamellars. And so this shows a case that with the coaxial microscope, you can't tell what the quality of this dissection bed is. But if we look down here to the inset, you can see here that on the right side, it's way too thick. It's actually too thick here, but it's also irregular. And if you're going to get a good visual result with your anterior lamellars, you have to have a thin, regular bed all the way across. And so the OCT can allow you to look at that and determine if you need to do more dissection, where you need to do it, and how to get a better result. So here's an eye that we've injected a fair amount of air. We didn't get a big bubble. And actually what I find is that my manual dissections are comparable visual-wise to my big bubbles. And the reason is the OCT. So here, if we look in the upper left and we compare it here, we still have a fairly thick bed, too thick to get a good result. We do more dissection here, and if you look at the inset, you can see that it's very thin. And this gives you a result comparable to a big bubble. And here we've begun to do the peel technique, as Dr. Malbrand and others have talked about. And if we look at the OCT, we can see we have a uniform thin bed here. And this area is just part of the area that's still being dissected. But when you get a thin bed like this, you know you're going to get a great result with your deep anterior lamellars. Now, what about the people we do deep anterior lamellars on that have cataract surgery? And as Mike said, because of the internet, this video is probably showing choppy for you, but this is a keratoconus patient with very thin recipient cornea. I had to suture the keratome incision down here just to close it. And what I want you to watch is the cornea when we begin to hydrate the stab incision. And you're going to see a fluid wave go across about half to 2/3 of the cornea. So watch, and there it is. And you can see that that fluid wave goes all the way to there. So the question is, what do you do about this? Now, with a coaxial microscope, you can't tell how significant that is. But when we begin to scan the cornea, and remember, you can't see where the scan line actually is, only the surgeon can, you'll begin to see a pretty significant double anterior chamber where that fluid wave has separated. You can see it there really well on the inset now, has separated a large amount of that old bed that had healed well, but you can always separate a lamellar dissection in the cornea. So that needs to be fixed. You can't just leave it. And the question is, how do you get rid of it? In this case, I'm going to open up the incision right about the area where my stab incision was. In other cases where I didn't want to open the incision, I've actually used a diamond blade to go in and make a drainage incision like we used to do for dissect grafts. So once we get this separated to where we've opened up this double anterior chamber without breaking the underlying bed, we're going to begin to inject fluid. I don't have to use air for this. I go through one of the other incision sites and I inject fluid, making the eye quite firm, raising the pressure, and then that'll drain through this incision that we made. And I might even go in and crack it a little bit to help it. But if you watch this, you'll be able to see that that area of detachment is decreasing, and it actually gets to the point where that original bed is up flush now against the donor cornea. And the next day, this eye looked perfect. he hasn't had any problems since. But without the intraoperative OCT, this would have been a difficult case to manage. Now, what I'm going to end up with is something totally different. This is a patient that a few months earlier had uneventful cataract surgery, and a couple days later, the operating surgeon found a nuclear fragment and went in and removed it. But his cornea went on to decompensate, and he came to us for a DMEC. And I found that there was still a nuclear fragment down in the lower angle, which on this screen is on the right-hand side. And you can see I'm going all through the angle with my phaco tip to get that fragment out. But due to the cloudy cornea, I can't really see it. And also the nuclear fragment's the same color as his iris. But I'm pretty sure I got it. But since I'm going to be doing DMEC, I've got my iOCT on, and I scan the angle. And now watch that inset, and you will see that there's actually a large nuclear fragment still there. You can see it there. Look at it. That thing's huge. If I don't get that out, he isn't going to do well with his DMEC graft. Now, what you can't see is that image that I showed you with the photo, that with real time, I can put my cross section right over that fragment. I can see where it is with the intraoperative OCT, and I can engage it with the phaco tip. And watch the phaco tip as it goes more centrally, and you'll see a big nuclear fragment. There it is, see it? And it is the same color as the iris. So without the iOCT, I wouldn't have been able to find that very easily. And I don't really want to have to irrigate a lot to blow it all around the anterior chamber. So in summary, these are the three images we see in the operating room with the iOCT. And the really important one is if you want to use this real time in surgery, either as the way Dr. Seibelman showed you or the way we do it, you want to have the Haag-Streit because you can see where it is with your cross section, and you can see the injection image here. Thanks a lot.
Thank you, Dr. Price. And Florian, I think we have a few questions for Dr. Price.
Yes, just a second. I just unmute everyone, and then gonna activate the webcams as well. Yes, let me have a look inside. Maybe the panel. Does the panel has maybe some questions to Dr. Price at first, and then I have 2 questions so far already. Okay, so the first question is, for how many % could you reduce complications while doing DALK surgeries?
Well, it's hard to say, but I really wouldn't want to do a manual dissection anymore without the iOCT because I can't tell the quality of the bed. I can't tell how thin it is safely. I've used the Mellis technique in the past where you put bubbles in the anterior chamber, but this is really much better. And especially if I'm doing a manual technique, I would combine it with things like Enrique Malbrand has talked about with the different ways that he does PALCs and so forth. But the iOCT just makes life a lot nicer.
Okay. The other question is, do you use special visible instruments for your DALKs? Usually the instruments are not visible with the OCT or making a strange shade. Do you have an idea how to reduce this shade of the instruments?
No, most of my instruments are metal.
Okay.
So they just cause some interference. I don't use it so much to place my needles, but I use it to judge what I'm doing with the dissection blades. As I showed in those pictures, I look at the bed and tell if I'm thin enough of it, if I've gone deep enough.
Mm-hmm.
So this is Chris. I wanted to jump in. In the posterior segment, that question, the idea of OCT shadowing from instruments, you can sometimes use the shadowing to help you determine positioning sometimes. But stay tuned. OCT translucent instruments are being developed.
Great.
Are being developed from whom?
Can't say.
Okay, good. Yeah, interesting. Okay. Yeah, let's see in the chat. No other questions so far. By the way, Sebastian, you are muted if you just have a question or something. Or, okay, no, I'll
Great.
mute
Yes,
you.
yes. Florian,
Yeah.
thanks. Because I have a question. Thank you very much for the very nice.
This is what I thought already.
Yeah. Thank you, Mr. Price, for the very nice talk. One other indication where we use it in a very similar situation you presented is acute corneal hydrops in keratoconus, where we at the moment really started to dehydrate the Descemet detachment in acute corneal hydrops. So this also works really good and really helps to monitor the reattachment of Descemet's membrane to the corneal stroma.
Yeah, it really allows you to see what's going on through a cloudy cornea.
Yeah.
I mean, you don't need to. It's nice to have stain on it, but you can really see firsthand what you're doing, and it's just a game changer.
Absolutely, yeah.
Going back to Dalks, I also like using iOCT to gauge needle depth when going for that big bubble. It's a technique that Frank taught me. Frank, do you still do that, or do you not need it anymore? You just get that needle right where it needs to be.
Yeah, I'm doing more and more peel techniques, but if I get a big bubble, it's great. If I don't, I don't worry about it.
Okay, no other questions, so I will give the lead to Dr. Fang. Okay.
Dr. Price, thank you for your presentation.
Thank you very much, Dr. Price.
You're fine.
All right. Thank you, Florian. And hi, everyone. Next, we're going to look at Descemet membrane endothelial keratoplasty, or DMEK. I hope the audio is working because this is going to be almost all video with minimal text. It's been a privilege and really quite a lot of fun to use Haag-Streit's intraoperative OCT or iOCT for DMEK and to watch the tech evolve and improve over time. This is footage from over 4 years ago for comparison. Already we see the iOCT picture-in-picture inset capability in the lower right corner here. Here we're checking the donor double scroll for correct orientation and using a handheld slip beam for added confirmation. The primary surgeon can inject the live feed into both oculars as an overlay, so there's no need to look away from the scope, but right now we'll have to watch the inset. Look here as the initial air bubble is going to float the donor upwards toward the posterior cornea centrally right there. And next we'll deepen the anterior chamber with BSS. Watch the iris move down or back. iOCT shows us that DMEK's various technical steps really are necessary, that the graft can sometimes be upside down in need of flipping, that the shallow AC initially helps to confine the donor, that deepening the AC restores working space after the initial bubble, and now, after unfolding and centering the donor, that the graft remains detached peripherally, as seen under the shadow from the cannula right here, after only an initial small bubble and a fuller airfill is needed. Now we're going to see that the graft becomes fully attached and the small edge lifts over here flatten as the bubble expands. By the way, we can easily toggle the ocular injection image feature on and off ourselves using the foot pedal switch. Now, you may be thinking, actually, I couldn't see any of that just now. So let's fast forward to the present, 2020, and try again. See how the iOCT signal strength has now been optimized. We can see the entire donor so well that we no longer require a backup confirmation method. We can see that this needle is under the graft, but not touching it right there. There goes the initial small bubble floating the donor up towards the posterior cornea centrally again, and now deepening of the AC and the iris moving back. After unscrolling the donor, the iOCT clearly shows that it remains mostly detached, though, awaiting a fuller airfill after we center the donor first using golf swings with our cannula, like so. I should mention that the iOCT is scanning horizontally relative to the primary surgeon's view. So in this case, where I'm sitting temporally, the scan is running from the patient's 6 o'clock to 12 o'clock. The line vector over here above the scan image also demonstrates the scan meridian. We can easily rotate the meridian being scanned as needed using the foot pedal. Now watch the graft detachments finally resolve as the fuller final air fill milks fluid out from the interface here and here and pushes the donor into place. The scanning beam can be seen in the OR by the surgeon and sometimes the patient as a moving red light, but it never seems to show up in the surgical video as others have alluded to. Now, sometimes at the conclusion of a case, we decide to add BSS to adjust or shrink our airfill or raise IOP. Here we're going to see a fluid wave within the graft interface. So look right here, yep, there it goes. And then it goes away, or does it? So looking over at the iOCT again, we see that there's actually persistent interface fluid. Because the interface separation is subtle, here it is again, but we've zoomed in on the picture-in-picture inset. This is the previous clip, same speed. The iOCT is going to clearly show the interface fluid coming from over here, and then a wave propagate. You see the graft come off, then incomplete resolution. Now, none of us would leave the OR with an already detached graft. We wouldn't do it with the second. We certainly wouldn't want to do it with DMEC either, where the detachment risk is greater. So thanks to this insight from iOCT, I recommend that if you need to top off with BSS, don't do it from the inferior paracentesis, only the superior one. And use a cannula as a roller to squeegee the interface in that quadrant, unless you have iOCT showing that that's unnecessary. This one adjustment to my DMEC technique dropped my rebubbling rate from 10% to under 5%. We'll later hear about looking at ICL vault using iOCT. This next DMEC insight from iOCT comes from that same plane though. In DMEC, the donor can be quite close to the IOL, especially early after graft insertion. How close? Look over here, look at that space. We know from cataract surgery that IOL corneal touch leads to endothelial loss. So thanks to this insight from iOCT, I recommend that the pupil be maximally constricted. This case here was a DMEC triple case, and intracameral myostatin was administered to constrict the dilated pupil from phaco. And cycloplegics and continuous mydriatics in the BSS bottle are to be avoided, so constriction is possible. We should also avoid pressing down on the donor directly over a pseudophakic pupil, or the donor endothelium may touch the exposed IOL optic. In this next case, we have a young donor which is fairly tightly single scrolled. We're looking at this in 4 times speed because it takes quite some time to unscroll. Notice that I'm tapping the donor over the iris and not directly over the pupil as we just discussed. And then notice now that there's an S stamp, but that it wasn't really visible until now. One of my favorite things about iOCT for DMEC is the confidence it confers looking at donor orientation. Unlike an S stamp, we can determine orientation much earlier during unscrolling, so we don't have to wait until we're almost done. We've almost done most of the work only to find out that the graft is inverted and we need to do it all over again, so saves time. Also, we don't need to risk additional cell loss localized to the area of the S stamp, although it's admittedly a small percentage. As Frank mentioned, in my practice, I don't use S stamps, but it was serendipitous that my eye bank provided this one by accident, so I have video to show us. Now, this is a DMEC rescue under PK. The DMEC donor is difficult to see through the hazy failed PK, but there it is over on the OCT. Without iOCT guidance, it would be nearly impossible to unscroll and center this donor properly. iOCT also shows how edematous the PK stroma is, over 800 microns. The view through a thick cornea really deteriorates even after tricks like epithelial debridement. Before iOCT, if the PACI was over 800 microns, I would only consider dissect because visualizing for scoring or stripping and visualizing a DMEC donor were just too unreliable. So iOCT has helped to expand patient eligibility for DMEC in my practice. And the final airfill you'll see has attached most of the DMEC except at the irregular posterior lip of the PK margin. I routinely order pre-op OCTs on failed PKs to decide whether the posterior surface is smooth enough to even attempt a DMEC rescue. But sometimes focal irregularities are missed that iOCT can detect as we scan around, and we can make adjustments during the case. So finally, I'll leave us with this glaucomatous bullous keratopathy case. You see the bleb there, and failed to dissect under 16 cut RK with previous AK dehiscence. The PACI is 1 millimeter, so 1,000 microns, and the view is awful, especially inferiorly. Usually a dissect is easy to see, but not here. Now we put in intracameral air, which improves the contrast, and together with the iOCT, we can ink out most of the failed dissect margin, but nevertheless, it's wise in this sort of case to ensure that we have removed all of what we intended, no less and also no more. Now, as we inject the donor, notice the very poor view. We can appreciate some blue darkening nasally. That's on the top part of the screen there, but that's it. So instead, for the remainder of the case, normally we're viewing here, right? But instead, I'm basically viewing here, specifically through the image injection to do the remainder of the case. The infusion, fortunately, allowed me with iOCT to see the graft, despite the hazy view, kind of as Dr. Siebelman was saying. And only in this way could I check orientation and unscroll the graft and finally get that bubble under there. And it's starting to look more familiar, again, in this view, not this view. Can't really tell what's going on. But we're going back to this view and relying on the intraoperative CT, we get the final fuller air fill in there, and you'll see that the graft has nice adherence and attachment, except focally in this one little area. Can't tell at all. It's right about here. Can't tell at all except on the iOCT, so I'm going to use my cannula a bit like a LASIK roller to squeegee until I see on the iOCT that I have full attachment. So this is a case not just guided by iOCT, but really requiring iOCT, in my opinion. Thank you.
Dr. Fang, thank you very much for your presentation. I know we have a couple of questions from the audience here, but let's open up to the panelists for questions first.
So Matt, this is Chris. What a great talk, and I'm really excited about the concept of the iOCT making previously inoperable cases operable because of the visualization that's possible. We're seeing that same thing on the posterior segment side. You mentioned several times, and Frank talked about the image injection. The image injection is binocular. And it's the only binocular image injection that's out there for intraoperative OCT, which really makes a big difference in terms of user friendliness and in terms of fatigue during the case. Have you operated with monocular image injection at all?
Only on exhibition, in exhibition halls. And there's one system where, if I recall, it'll flip depending on where the oculars are, and there's another one where it always seemed to be the same eye. I'm a bit left eye dominant, so as you can imagine, if it only is going into my right ocular, I really have a hard time with that. And with the Haag-Streit system, that's not a concern. So yeah, I agree with your point 100%.
And Florian, we have a few questions from the audience as well.
Yes. Let me just have a look. I have to move some windows here. So the first question is, can you see actually the graft also through cloudy corneas? I mean, we have seen it already, but also through blood. I mean, if you have a blood in the anterior chamber, or will it be reduced the view?
Yeah, so that's a great question, and yes, you can. I have another series of videos, but sadly, my 10 minutes was up. Or I would love to have shown them maybe another time. But you can see with the iOCT, fibrin clots. You can see the graft through hyphema. You can see vitreous prolapse. Never a fun feeling to detect that, but you can see that too. So really a very versatile piece of equipment. Essentially everything that we can do in clinic with our anterior segment OCT, this allows us to do in the OR, so we don't have to be messy and close up a case, send a patient upstairs, send them back down again. I mean, just get it done on the table. So talk about improving patient outcomes.
Okay.
So I'll just add that, you know, as Matt showed, the resolution of the OCTs improved over time. And so early on, the blood in the anterior chamber would wipe out the image. But things have really improved with the newer versions.
Okay.
What about imaging through corneal blood staining?
That's a good question. I haven't had the need to do that so far, but I suspect it would work because, again, I've had to do that in the clinic and have been able to get some images through even some significant staining. Has anyone else had experience with that?
Yeah, here. It works. It gives me a view sometimes posteriorly where I don't have one, or a better view and where I don't have one using just the image through the microscope.
Okay.
Great,
Okay.
Dr. Fang, thank you so much.
No, I have two more other questions.
Oh, two more questions. Okay.
If we have the time, I mean, you have the time in your eyes. Okay. One question. Do you think you actually need the staining of the graft or the stamp? Is it still needed? And also another question is there maybe an advantage while you're doing the graft preparation by using the OCT?
Right. So, so first question, you know, I would love to say, yeah, you don't need the S stamp. As I mentioned, it's not my practice anymore to, you know, request one. Less manipulation preparing the graft, less endothelial cell loss. I think it's gentler on the donor tissue. As far as staining, presumably talking about with, you know, Vision Blue, Trypan Blue, I think I would still recommend doing that. I fear I'm becoming so dependent on iOCT. What if one day it breaks down, you know? But if I still have staining and still remember how to do it, you know, in the old school way, that would be helpful. But certainly I know that you can visualize it without any staining because on very difficult cases, sometimes your stain does begin to wear off and your graft is essentially invisible, except with iOCT, you can still see it. There are ways to restain it within the anterior chamber, but sometimes that can be messy, as we learned before iOCT. So these days, really, it's been a blessing to have iOCT. As far as using it during preps, you know, we have the iOCT on during donor preps for DMEC. I have to admit, though, I don't really refer to it all that often. Fortunately, our rate of issues and tissue loss during preparation is less than 1%. And so the need doesn't arise very often. But certainly, you know, the technology is there to take a look if necessary to try to detect adherence or something of that nature. So it could be useful, but I find more of the uses actually in the recipient eye.
Mm-hmm.
Yeah, I'll just make a comment on the stain. I think you still need to stain the donors so you can see during the insertion process. The iOCT helps us once the donor's in the eye, but for DMEC, you want to be able to look at it in whatever inserter you're using and being able to make sure that you're getting it into the eye appropriately.
Dr. Fang, thank you so much for your presentation. And now we're going to move on to Dr. Zalvadar.
Okay. Good night for the people in America and very night for the people in Europe and the rest.
Thank you.
I'm going to change a little bit the topic. I want to try to finish in this talk why for me now is mandatory use OCT when I put phakic IOL, especially ICL. That's since I put the first ICL in September 1993, 27 years ago. Today, the ICL was put one ICL every 2 minutes in the world. Not now because they have the coronavirus, but normally. And in 1994, we made with Vladimir Fengel and the engineer Alex Kosminit the first perforation in the like a central hole to try to avoid pupillary block. They took 17 years later to do the first ICL with central hole commercially. But the importance of this was like the meta-analysis done by Mark Packer about the performance of the ICL with central holes revealed
the dramatical reduction of the main complication of the phakic posterior chamber lens, that is cataract. And if you see all these papers reveal that have almost no cataract in the patients. And the reason of that is like this hole allows circulation under the lens and push the circulation to the anterior chamber. In other meta-analysis done by Packer also, all authors agree in clinical significance the bolt outside the range, and the adverse events that produce are pupillary block, anterior subcapsular opacity, and pigment dispersion. Basically, the main problem that we have now, is the hyperbole. And the question is there a way to predict a bolt? There are popular formulas for predicting bolt now. The most popular are Nakamura and Akihito, and both using OCT and pentacam, that mean OCT of the anterior chamber. I do 42 eyes of 25 of my patient, and I measure the bolt with OCT intraoperative and 24-hour the surgery. The blue line mean what is the real bolt, and the red line what is the prediction of the Nakamura formula. And as you see here, there is no any correlation between the prediction and the bolt that we get. Also, we did the same with Akihito, and as you see, the blue line is the real bolt, and the gray are the real the calculation of what is going to be the bolt. That is no prediction. That basically, the mean error is more than 250, but there are sometimes more than 1,000 microns error in prediction. To conclude, there is no way to predict bolt with anterior chamber measurements. And the reason of this is no correlation between ciliary body to ciliary body, sulcus to sulcus, angle to angle, and wide to wide. That is, you see here, the blue line is ciliary body to ciliary body, and the rest are the other measurement that there is not any other correlation. To be more precise, in the left are the wide to wide, and in the right is the angle to angle. The coefficient of correlation is 0.32. When you compare wide to sulcus, is 0.28. And we compare wide to ciliary body is 0.29. That means no correlation at all. We correlate angle to angle that also be seen in the with OCT in the anterior chamber. The correlation is a little bit better, 0.6, but still is very bad. And if we compare angle to sulcus, it's 0.68, a little bit better. Then we thought if we measure sulcus to sulcus, we are going to get better prediction. But the meta-analysis, another meta-analysis of Marca show that all the authors, they using sulcus to sulcus or wide to wide have the same results. Why they have the same result if they're using a method that really is supposed to be better? Where is the mistake? You see these images, you can see an ICL, and you can see the fit of the ICL is in the ciliary body in these images, in both sides. In these second images, one fit is in the ciliary body and the other fit is in the sulcus. And as you can see, a real asymmetric ball. In this one, you can see that is sulcus to sulcus in both sides. And this one is a hyperopic ICL that is really in the sulcus. But let me be surprised. Do you know how many people go to the sulcus to sulcus? In myop eye, in 54 eyes that we check, only 3.7%. That means 83.3% of the lenses don't go to the sulcus, go to the ciliary body. All the formulas based on sulcus to try to estimate what is going to be the ball, but only 4% of the ICL go there. even the correlation sulcus to ciliary body, that is really the place that they go, is only 0.75. That is acceptable, but not good. Then, if all the people do it wrong, why do ICL surgeons have very acceptable results? Because if we are inside the blue line, that is a very big area, we are okay. We are okay with 200, and also we are okay with 900. That means we don't have to predict well. We have to be inside this area. But the problem is, when you get something outside this area, how to solve it? And there are 3 new tools that I want to speak. I want to speak only in OCT intraoperative, but I want to mention the other ones. The OCT is something that is mandatory for me now. I developed a software to predict what is really safe vault, and also the new ultrasound for the posterior chamber. The safe vault to estimate, the software to estimate the safe vault is a software that, based on anatomical finding, and also the vault that we are going to expect it in 20 years, putting the information of the anterior chamber deep, power of the lens, HCD, and most of the information, they bring you the information in the green area, what is going to be safe in this patient. The blue is going to be, is safe, but it's acceptable, but it's not perfect. In the violet, it's not acceptable, and in the red, it's not acceptable. That this software changes with every patient. We're going talking more now about intraoperative OCT, how they changed my life. There is a paper that has just appeared this month, a comparison between intraoperative optical coherent vault and different measure between 1 day and 3 months. And the conclusion at the end is that the intraoperative ICL vault invasive but OCT correlate highly with postoperative OCT vaulting, and is very predictable for ICL. And in this paper, they show that they have mean 731 intraoperative, and in 3 months is 632. Even that is about 100 micron different, there is a very big correlation, and a very big correlation between 1 day and 3 months. I mean, 1 day vault is a very important measurement. I did a study instead of Torby. This study was with 45 eyes. I did it with 592 eyes. And if you see, the mean of intraoperative vault with OCT was 656 micron, and the mean 1 day vault was 625 and 25, very close, a little bit less, but very close. And this is more in details what I mentioned. The mean is very, very close. And as you see here in the middle, this is just the correlation between vault the OCT versus 1 day, and an average is 1 day is 36 micron less than intraoperative. That means very close. This is a spread. This is the images of all the patients done at 4 hours and 1 day. And basically, I wanted to show that in my surgery, the position of the ICL are horizontal only in 81%. But I have many, 15% that are vertical and 3% oblique. But the media vault, 24 hours and 1 day, in the 3 group are about the same. That about a little bit more than 600 microns, the mean in horizontal, vertical, and an oblique position. In ICL, I rotated intraoperative, and if you can see, I can rotate the ICL in this series about 5%. Basically, what I say is how it looks like in the operating room with the OCT when I do ICL. And if you see there, I'm not sure if I am doing the surgery now, but basically what I do is checking the vault when I finish. I'm not sure it's there because I cannot see anything here.
Yes, it's there, and now we are showing the measurement.
Okay.
Right
then
now.
I clean I clean the viscoelastic. Basically, what I do is put the lens, clean the viscoelastic, and take the measurement. And in the case of this video, I show that I check the central bolt and the periphery bolt. You are going to see that I can check the shoulders of the ICL, but I'm not sure what is the video now running. Yeah, you can see this in the video or not? Now
yes, we could see that. We could see that in the video. But I will give you back the presenter.
Slides.
Yes,
okay.
I will give you back the slides.
In the last series, I rotated about 4.5% of the patient. Next, they don't move. You can move the slides?
No, just click in the slides and then just change right and left.
Okay. And basically, what we happen with when we rotate the slide, that is the most important thing, is in gray is the bolt intraoperative, and in blue is the bolt that we get inside the operating room when we rotate the ICL 90 degrees to the vertical parameters. That means there is a very important reduction of bolt inside the operating room, and the brown is what we get one day. And as you see here, we can reduce between 370 and 400 and 500 microns reduction of one day. In the other video that you see here is what happened. I do not only choose put it vertical. Sometimes I choose put it oblique, because with oblique you get a little bit less reduction. As you see here, the gray is what the bolt intraoperative, and the blue is with the rotation between horizontal position to oblique position. This is the real position of the ICL before and after the rotation, and you can put the second video that maybe happened, maybe you can see, but in this slide you can see the OCT before and the OCT after, and it's very clear. There is a video that shows the rotation. I don't know if you wanted to show or not. The video shows how we rotate the lens inside with viscoelastic, and basically we can reduce between 300 and 500 microns inside the operating room. Can you share the slides again?
Yes, I will. I will give you back.
Okay.
Presenter. Okay, now you're a presenter again.
Okay. That basically this is how it look like in the OCT. You see the big bolt that we have before rotation and almost a half bolt after the rotation. Basically, in our software show that we are in this area, the violet area. When we saw the measurement in the operating room, we saw that we have almost 1,200. We are in the violet area. And when we rotate, we go to 500, almost 550 in the green area. That means even if you don't have this software, you know that the other bolt is very big because you measure. As conclusion, understanding where the ICL host will serve to make a lot new formulas. Intraoperative OCT is a great help to avoid extreme bolt, and software is a secure bolt allows to increase the security of the ICL. That means for me now it's mandatory to use OCT, and always at the end of the surgery I finish with the best bolt that I can, and not the bolt that I have at the first time. That's the end. Thank you.
Thank you, Dr. Zaldivar. I know, Florian, we have a couple of questions from the audience, but I'd like to open up to the panel first for some questions for Dr. Zaldivar.
Roberto,
yeah, I have a video, or I'm not have a video. Okay. I have to go out the screen. How to go out the screen?
You don't have to.
Hello?
I would change this.
Okay.
I would change this.
Okay. Yeah. Yes, I listen.
So Roberto, you're
Yes,
always You're always helping us in finding better ways to do surgery. It's all very nice. So
Thank you, Frank.
you do your measurements without constricting the pupil. Is that right?
Yes. The measurement, I don't put a myocho because the central hole, you need to put a myocho. That means I make the measurement dilated without viscoelastic after cleaning the viscoelastic in the operating room. That I measure, I clean the viscoelastic, I take the measure. If the measurement is too high that I don't like, for example, not always the same, but sometime between 900 and 1,200, then I decide to move. If I decide is the ball is too much, I go directly to vertical. But it's in the limit. For example, I don't like 900. I like to have a little bit less. I put oblique. And oblique is in the middle of vertical and horizontal. Always, always vertical. When you put vertical, the ACL have less ball than horizontal. Always. Sometimes a little bit, sometimes 500 microns, but always less. This is the question, Frank, or other thing?
Yes.
I don't use myochol never, because when central hole do you need, that's the important thing, because my measurements are very reliable, because when you put myochol, then the problem is the pupil is too small and push the lens back, then the bolt is false. It's not true. That the measurement had to be done without myochol. And it's a very big correlation between without myochol in the intraoperative measurement with 4 hours later and also 1 day later. And there are other papers that say 1 hour later or 1 day, the measurement of 1 day, they have a very big correlation with 3 months. That means it's almost the same. And there are other papers who talk about between 6 months and 10 years, you lose about between 15 and 20 microns per year. That this is the calculation that you had to do in your brain to have a safe ball 20 years later. I'm not sure if I'm clear.
No, you are.
Thank you, Dr. Zaldivar. Great presentation. Dr. Riemann, we're going to go ahead and move right on to you here.
Excellent. So can everybody see that?
Yes, we can.
Yeah.
Wonderful. Well, thanks, Mike and Florian, for the opportunity to talk today. And thank you to my fellow panelists. Really great stuff. And I'm becoming, I get excited as a retinal specialist seeing things that I don't really know much about. So I'd like to talk a little bit about the iOCT in vitreoretinal surgery. We already mentioned that in the US, the 510K is applied for, but it's not, we don't have it quite yet. We all understand the anatomy of the posterior segment. And I just wanted to note that, the retina is somewhere between 80 and 320 microns thick. And we can see the retina on an almost cellular level with intraoperative with optical coherence tomography. Normally here up top in this top image, and then you can see an epiretinal membrane with some cystoid macular edema here down below. Now the interesting thing about that is that this 10 micron axial resolution that we see here of the retina, this is in the same ballpark as the 500 micron thick vitreous cutter that we see here on this left frame, the 150 micron wide vessel, and the 1 to 4 micron thick internal limiting membrane that's being peeled. And here you can see the thickness of the retina with a retinal vessel and a shadow of the light pipe, which is coming in from superiorly, hitting the underlying retinal pigment epithelium. And you can see that there's actual thickness to the retina in that picture. So OCT really is particularly well suited for posterior segment interventions. So kind of another way to think about this, here's a satellite view of the Grand Canyon, and which is akin to a slit lamp 90 diopter or binocular indirect view or a surgical view of the retina. And with the OCT, we really get down and dirty and we can see the topography of what's going on in the back of the eye. OCT is indispensable for medical retina, for pre-op evaluations of surgical patients, and for post-operative evaluations of surgical patients for a whole host of diseases, and this is just a partial list. So you asked the question, if we find OCT indispensable in the clinic, could it be useful in the retina operating room? So, you know, we know that OCT, it can image without a contact lens, can image the anterior segment. This is the Haag-Streit unit, looking at the cornea and the limbus. It can image macular detail with a direct contact lens. Here's a live view. It's jumping around a little bit because the patient's moving during an epiretinal membrane peel, and you can see the membrane elevated off and some shadowing from the instruments that are manipulating that membrane. And you can use the intraoperative OCT for wide-angle viewing through the IBOS 2 wide-angle viewing system. This is a macular cube. You can see the macula. You can see the optic nerve come into view. And the OCT can see all these structures in the posterior segment. It can image through vitreous, through BSS, through perfluoron, air, gas, and of course through silicon oil. So here's a patient that presented back in 2013 with 2400 vision and a retinal detachment with a full thickness macular hole. I'm going to let this video play, and you can see that the surgical view on the left and the OCT view here on the right. I've edited the two together, and you can really see the macular hole as the cause of this epiretinal membrane, of this retinal detachment. Here we've put perfluoron into the eye, and we've reattached the retina, and under perfluoron we're peeling the internal limiting membrane, and we can see that the macular hole closes. Then we do an air fluid exchange, and we can find occult subretinal fluid that we can drain under direct visualization with the optical coherence tomography, with the OCT, from the macular hole, getting closure of the macular hole. This patient did really well and had a very good visual acuity result with over a year's worth of follow-up. So, you know, that's just one example. It turns out that there's been a lot of observational studies done on hundreds of eyes, showing that in both the anterior segment and in the posterior segment, we have somewhere between a 30 and 40% rate of the OCT actually being clinically useful in terms of intraoperative decision making. So we wanted to look at, we did a little study a few years ago. We wanted to look at, see whether or not the OCT could inform our understanding of what goes on when we're fixing macular involving retinal detachments with PFO. So we used the Haag-Streit OCT, IRB approved. We operated 9 patients with a macular involving retinal detachment. We did the standard retinal detachment repair surgery, and what we found, obviously, these were all MAC-off RDs that had significant amounts of subsensory fluid at the beginning of the surgery. Here's one example. Then what we did is we put in the PFO, and under PFO, we saw that the macula reattached with either complete resolution or minimal residual fluid in the subretinal space under PFO. But the new and interesting finding is, even with an exaggerated air fluid exchange to really make sure that we dried the brakes, what we found is occult subsensory fluid under air in all eyes. So here we're imaging through air. You can see the reaccumulated fluid under air, and that's really important because, number one, it's not been shown previously that even when it's clinically dry, there's always fluid under the macula. 9 out of 9 eyes in this small series. And the OCT findings provided objective evidence to help us explain the problems that patients sometimes have with post-op metamorphopsia, macular folds, and retinal slippage that can sometimes plague us even when we use PFO to operate macula involving retinal detachments. And the OCT now demonstrates a logical rationale for face down positioning or nasal down positioning in these patients. So, you know, this work has been published and presented as videos and as a manuscript. And it's just one example of the myriad of ways that the intraoperative OCT is useful for postoperative for posterior segment surgery. Retinal detachment surgery, we already talked about, epiretinal membrane peeling, vitreomacular traction, macular hole repair, proliferative diabetic retinopathy patients. We can also look at sclerotomy architecture and subretinal injection. So here is the bottom left here, we see a straight-in sclerotomy after we've pulled the trocar out at the end of our case. You can see with a straight-in sclerotomy entry, the scleral wound is open and you have a bleb, so you have a sclerotomy leak, and the conjunctiva is lifted off the back wall of the eye. Here in the top right, you see that there's a 30-degree beveled entry, which is the way I like to make my sclerotomies. We pull the trocar out, put a little tiny bit of point pressure right here, and we see that there's no elevation of the conjunctiva and no leak. Again, the OCT shows us whether it can sometimes show us whether or not we have leaks. Here's a Luxturna injection where my partner Robert Sisk does a lot of these. We're a Luxturna site gene therapy for RPE65 disease. This is what a formation of a subretinal bleb looks like with intraoperative OCT. So this is a competing unit. You'll notice that we're using that the quality of the image is not so good. You'll also notice that we're using an iPhone to capture this video because the workflow is of capturing the video is difficult. So, in 1928, Herbert Hoover was running for president, and he told Americans that if we elect him, there would be a chicken for every pot and a car for every yard. So the question then is, if OCT is so fantastic and intraoperative OCT has been around for a long time, should there be an iOCT in every operating room? Well, there isn't, and most of us don't have intraoperative OCTs, and the uptake for this technology has been slow. And the reason for that is that there are real barriers to entry for this technology. A lot of the currently available OCTs have a bulky form factor. You have a trade-off between shallow scan windows and poor axial resolution. The OCT acquisition workflow and the display workflow is very limited. The image injection on some of these units, as we've already talked about, is monocular and is of poor resolution. The video recording can sometimes be wonky and difficult. There's been issues with robustness and reliability and consistency of as these units get bounced around in real-world use. Cost, Frank had already mentioned that, and whether or not these are compatible with digital with screen-based surgery. So what I would just like to tell you is that with the next generation Haag-Streit unit, these problems have been solved. So we've already seen various iterations of these pictures. The key thing here is that the iOCT is fully integrated into the Haag-Streit microscope. It's a low profile camera with a beam splitter that sits right over here. You have a touchscreen user interface. You also have an intuitive and customizable foot pedal and touchscreen based workflows that makes it easy for the surgeon without an assistant to acquire these images and manipulate the images and change how and where and what angles and what settings you use to acquire these images. You also have the ability to see your captured intraoperative OCT in full high resolution with both image injection and on the little screen that's right next to the surgeon, as well as on the big screen that hangs off the microscope. You also, and the big screen, you have integrated recording with the MyOS control system, integrated recording of the OCT, of the surgical field, both as separate video streams as well as overlaid on top of one another. It's a very, very user-friendly and powerful way to get this information to the surgeon, and then also to get it to presentations as we give talks and show intraoperative OCT videos. So I won't bore you by going through these, except for to say that that it is a robust intraoperative OCT with great parameters. And you can do single line images, different volume scans, And of course, you can do live streaming single A scan line video. I do want to spend a little bit of time talking about integrating. This is, I am a huge fan of screen-based surgery, and the intraoperative OCT has, I've just paused the video here for a second, has a plug and play. The Haag-Streit unit has a plug and play functionality with the Ingenuity. So, and it's very, very powerful. What you're seeing here is a 2D rendition of what I'm actually looking at. Here on the left, you see this is actually a 3D image. That's my primary visualization of the back of the eye. I do not have oculars on the microscope. Here on the right, you see the intraoperative OCT, that the video feed that really brilliantly presents it. Now let the video play here in this membrane peel surgery. So I flipped the two images because I like operating with a live image on the right. You can see the poster, a little bit of vitreomacular retraction syndrome. Here I've turned the image injection on. You see the brilliant image injection resolution on the right, but you see that the full resolution OCT on the Ingenuity is actually even better than what it is with the image injection. So displaying them live side by side allows me to actually, here I'm peeling the posterior hyaloid. You can see me lift the posterior hyaloid off the optic nerve, and I can go back and forth and very easily capture the video. If you look in the top left-hand corner here, I'm putting ICG into the eye, which means I'm extincting my, I'm wiping out my OCT image. If you look in the top left-hand corner, this is a real timer that shows how I'm operating. Now we've taken the OCT out, and bang, we use the auto rangefinder, and I've got a brilliant OCT image that shows me the macular pucker. You look at the image injection on the right, which is overlaid and nicely captured by the camera. But for me, I would rather turn the image injection off and look at the full resolution image. Here I'm looking with a direct contact lens, and I immediately get a brilliant view. And now I can lift it, and we can see the epiretinal membrane being peeled off the surface of the retina. And I find myself going back and forth between the live image and the OCT, and the live image and the OCT, which is easy to do if they're simultaneous, side by side, being simultaneously viewed. It's very, very powerful, and it really takes the OCT image and makes it more useful for the operating surgeon. If I had to look away from the surgical field at another screen in order to see this, the OCT would not be as useful for me. So I'm going to just mention that we've actually recently published a paper that basically describes the concept of an information handling cockpit. We used the Ingenuity system and looked at 12 cases of endoscopy, and then looked at 24 cases of intraoperative OCT. And I'm not going to go into the differences, but we looked at the Haag, the Leica, and the Zeiss rescan units. And the paper does a nice job of kind of delineating some of the differences and contrasting that. And I urge you to take a look at that manuscript. It's open source for anyone who wants to look at it. So the idea of an information handling cockpit, where you see the real world and then you see the instrumented imaged world at the same time in a way that's useful. So the OCT and vitreoretinal surgery are essential for the effective management of vitreoretinal disease. Intraoperative OCT combines these two elements and is a natural next step, which informs surgical decision-making and also informs our understanding of the pathophysiology underlying our vitreoretinal diseases, surgical vitreoretinal diseases, and our surgical interventions to deal with that. And then, the Haag-Streit OCT is fully integrated into a very capable Haag-Streit retina microscope, and extensive and has extensive surgeon-driven design and usability features that, combined with true high-resolution rendering of the OCT, makes it easy to see the brilliance and the brilliance of the OCT images in a way that's really user-friendly, really surgeon-friendly, and I think is a best-in-class offering of commercially available OCT units right now. And I've got extensive experience with all of them personally. And then I think that integrating the intraoperative OCT with some sort of screen-based viewing is very, very powerful, and strongly recommend this for my vitreoretinal surgery colleagues. And I'll stop here and be happy to take some questions.
Thank you, Dr. Riemann. Really appreciate the presentation. Florian, I know we have a couple of questions from the attendees here. I'd like to open up questions from the panel very quickly.
Well, Chris, I have one for you. When you have that retained fluid, why don't you just go in and drain it? I don't do retinas.
So if there's a macular hole, that's exactly what we do. Okay. If there's no macular hole, it would be unfortunate. Sometimes we'll make it posterior drainage retinotomy, but there are several of us that believe that gratuitously making holes into the retina is probably not a good idea, although sometimes we do it. Depending on the geometry of the retinal detachment, sometimes, oftentimes we can just leave that fluid and position the patients, always end up with a bubble in this scenario, and position the patient so that the bubble manages the fluid and avoids the retinal fold.
Yeah. Okay. There's actually 2 times the same question. I tried to put that together. Do you think you can do a peeling without a dye, and how long are you using already the iOCT?
So I've been using in various different operating rooms and in various different scenarios the intraoperative OCT since 2013, 2014. Various different intraoperative OCTs from various different manufacturers. So the answer to your question is, can you do a peeling without dye? I have gray hair. I don't know if you can see that, but I have gray hair. So when I was trained, we didn't have dye, and so the answer, and we did peelings. So yes, you can do a peeling without dye. You can do a peeling, I think, much more precisely without dye using the intraoperative OCT, for certain, yes.
Okay.
Christopher, Roberto. Hello, Christopher. You can listen to me?
Claro que sí.
Congratulations with the images in the retina. It was amazing. I don't understand how is the setup of the 3D surgery. How do you use the OCT at the same time when you see a 3D? You can explain me how do you do the setup?
Yeah, so you take it's a plug and play functionality that's unique to the Haag-Streit system. The OCT, there's a couple of different ways of doing it. Basically, you take the HDMI out of either the MIOS or of the OCT unit itself. And you plug them into the auxiliary video on the Ingenuity. Works great.
Okay. Okay.
So actually, you remove the eyepieces from your microscope. You put on the Ingenuity system, and then you just split the screen on the Ingenuity system. Yeah. So you have the 3D image and the OCT image there. Yeah. Okay. There are so far no questions anymore.
Okay. Well, I appreciate everybody taking the time to visit and spend time with us in a webinar. On behalf of Dr. Siebelman, I know that he had to leave earlier, but Dr. Price, Dr. Fang, Dr. Zaldivar, Dr. Riemann, thank you so much for your time and for really helping to explain to everybody, again, how the OCT, in your experience, has helped to provide better outcomes for your patients, and how it's really changed in a lot of ways that that you've operated over the years. I know that there are a number of questions that we have not gotten to, and for those of you that do have questions, please reach out to us, contact us, and we will put you in touch so we can get those questions answered. And again, on behalf of the panel, on behalf of everyone at Haag-Streit, our entire global team, We thank you for joining, and we wish everybody a good night, and thank you again.
Thank you.
Thanks,
Bye-bye.
everyone.
Thank you very much.
Bye-bye.
Bye-bye.
Thank you.